All right. So this is also something that's new in these guidelines. So we know that the sensitivity of a TB symptom screen is reduced during pregnancy. So the recommendation is to do a TB gene expert regardless of symptoms on all pregnant women who've got a new HIV diagnosis or all known HIV positive women who've got a new pregnancy diagnosis. So in women with TB symptoms, and so this has been discussed a bit in the last few days too, so I'll try and unpack it a little bit, but in women with TB symptoms, the previous guidelines thought, okay, well, if we start triple therapy, are we going to put these women at risk of IRIS if they actually do end up having TB? But in the discussions, in the expert discussions around the guideline development, it was thought that whether you are using triple therapy or AZT monotherapy, it probably doesn't make a difference in terms of your risk for IRIS. So the new recommendations are that if a woman does have TB symptoms, but she doesn't have any danger signs, you can actually initiate her on triple therapy on that same day while you're waiting for her gene expert results, okay? But obviously, if you're worried about this woman and you really are very, very concerned that she's got TB, although you don't want to delay initiating your antiretrovirals, you may want to delay for a short while you actually get her onto her TB treatment, and then very shortly after that initiate antiretrovirals. Remember, pregnant women don't fall into the same category as other adults where we've got a bit of time to play with and we can start our ARVs later. We need to get those antiretrovirals started as quickly as possible so that we can get that viral load down. Okay? All right? And then in terms of our viral load monitoring and response, and I'm pretty sure that everybody is familiar with this, but just to remind us that viral load, if it's suppressed, it confirms good adherence and viral suppression, and it's probably our closest kind of proxy measure of adherence in our clients. But it also helps us to timeously detect factors which are negatively affecting our viral load. Okay. So there's a new thing which I think clinicians will be very excited about, especially if you've been kind of caught in the gatekeeping rules system where your repeat viral loads get rejected. The new guideline, or the new component of the guideline, is to put this code on each of your samples that you're actually testing viral load in pregnant or postpartum women. Okay? And hopefully that will help alleviate a lot of these gatekeeping issues. So we're still discussing viral load monitoring and response. And so you'll see that in this section of the guidelines, there are actually a few new changes, okay? So, I mean, and some of this is similar to what we've done before, but there is something new, which particularly is the viral load that we're doing at delivery. So let's go through each case scenario. So if we've got a newly diagnosed woman, and she gets initiated on antiretrovirals for the first time at antenatal clinic or at her first visit, we do her first viral load at 3 months on antiretrovirals, and then we repeat the viral load at delivery. Okay? In women who are known to be HIV positive and they're already on antiretrovirals, and these women are becoming more and more common in our programs. In fact, I think sometimes about 50 to 60% of women are actually already known to be HIV infected when they present to antenatal care. We do, as we've done in the past, the viral load at that first booking in antenatal clinic, and then again we repeat the viral load at delivery. Known HIV positive women who are currently not on antiretrovirals but may have been on antiretrovirals before, so either for PMTCT, and as you know, since 2015 only we've actually been giving triple therapy to all women. So there are women who would have just received PMTCT for that period and then discontinued. But then also there will be a group of women who were on antiretrovirals but discontinued for whatever other reason, not necessarily related to stopping from a PMTCT point of view. So in those women, and this is different from the other adult guidelines in terms of the viral load, we actually do a viral load on these women before we restart antiretrovirals. But we don't wait for those results, okay? We start the antiretrovirals. We repeat the viral load in 1 month in these women. If there's a more than 1 log drop, we continue and then we repeat the viral load again in 2 months. By that stage, if the regimen is working, those women should be suppressed, okay? And then, as per that, if the woman is suppressed, we repeat the viral load at delivery. If she's not, then we need to obviously go into the viral non-suppression algorithm. So the reason that the new change has been brought in terms of doing the viral load at delivery is that we want to know what this woman's response to antiretrovirals was during her antenatal care. It helps us to determine what prophylaxis we are going to be giving HIV-exposed infants, okay? And then it helps us to recalibrate our viral load time points during breastfeeding. So it gives us a good roadmap of, okay, what path are we following with this particular woman? Where do we need to do our viral loads for her? What infant prophylaxis do we need? The viral load also then gets repeated at 6 months after delivery, regardless of the woman's breastfeeding status, and then 6 monthly after that, aligned to the infant's 6, 12, and 18-month visits. Okay? So just to refresh everybody's memory, the viral load suppression is defined now as less than 50 copies per ml. Anything higher than that is a medical emergency, and particularly in pregnant women, we need to have a strong plan of what we're going to do next. And also, if we measure the viral load, we need to respond to the results, okay? And I think that's been discussed today. There's no point in kind of doing 3 monthly viral loads if you're not going to actually do something about it, okay? So viral load, we have to have a plan about what we're actually going to do. So if the viral load is elevated above 50 copies per ml, we obviously need to do a thorough assessment. We need to implement our interventions, and we need to repeat the viral load to confirm resuppression. Just to remind us, this little mnemonic, or kind of, I suppose, visual aid or kind of learning aid just helps to remind us of what the things are that we need to think about if we have got a woman who's got an elevated viral load. And just to remind us, it's around adherence, it's around if there are any bugs or infections that we need to be diagnosing and treating. Is the woman on the correct dose? Are there any drug interactions that we need to consider and need to be aware of? And we've discussed many of those. Or then, does she actually have resistance? And so that's also something that we need to consider. You'll see that this algorithm looks a little different to the elevated viral load algorithm in adults. And obviously, as we know, the reason for that is because in pregnant women or breastfeeding women, there's much more urgency in trying to get that viral load suppressed, and if it doesn't become suppressed, we need to think very quickly about switching that woman to another regimen that will get her suppressed, particularly if we think that she may have developed some resistance. So, and if a woman has got an elevated viral load, more than 50 copies, obviously, as we've discussed, we need to think about all the reasons for why her viral load may be elevated. If it's between 50 and 999 copies, we need to repeat it in 8 to 10 weeks. Okay, so this is both for antenatal and postnatal. So it's either going to be timed to the antenatal visits or it's going to be timed to the postnatal visits or EPI visits. And the reason that there's that flexibility is to try and tie it into the visits as closely as we can. Okay, so it's really for a practical reason, partly. Obviously, if the viral load is still in that category, we do need to watch it closely, but we also then need to be thinking about whether if the woman is, for example, on an efavirenz-based regimen and we want to switch her to a dolutegravir-based regimen, we need to consider, that she would fall within that category based on this assessment, okay? If the viral load is elevated, depending obviously where we are in the pregnancy, so antenatally we need to again figure out, do we need to keep this woman on the same regimen or do we need to switch her? But if she's postpartum, we also need to think about what are we going to do with the infant, okay? Because now the infant is at risk of becoming HIV infected. So we either need to start, restart, or extend infant prophylaxis, okay? And then we'll repeat the mother's viral load in 4 to 6 weeks. And so we'll talk in much more detail about the infant regimens in the upcoming slides, okay? So I realize that this is sort of very algorithmic and there may not be a lot of detail, but we will unpack all of this as we're going on, okay? And then if the viral load remains elevated, as we've discussed, we need to think about switching this woman to a second-line regimen, and we obviously need to think about what regimen is she on at the moment, how long has she been on antiretrovirals for, and the same principles will apply as we've already discussed. So I'm not going to go into any detail around this because we've had a detailed discussion around this, but same principles apply. Efavirenz-based or NNRTI-based regimen to a dolutegravir-based regimen if that's the suitable regimen for the woman, depending on what her future fertility desires are and contraception, etc. And then to a protease inhibitor-based regimen, so either lopinavir, ritonavir, or atazanavir. Okay? And just a reminder that on a dolutegravir-based regimen, we worry, or lopinavir, a ritonavir-based regimen, we know that the reason for that elevation is more likely to be poor adherence than actual resistance having developed. So we may not switch immediately, but we do have to remember that in a pregnant woman, if we're in any doubt, we do need to consult with an expert and think about whether we want to switch this woman earlier, because regardless of the resistance mutations, that baby is at risk of HIV infection if the maternal viral load is elevated. Okay? All right, so we've essentially discussed all of these aspects which will make up the ideal PMTCT pathway for the mother. So we can discuss now our antiretroviral therapy during labor and delivery. And so this is another key time point where we actually want to minimize as far as possible any risks of HIV transmission. If the woman is HIV positive and she's on antiretrovirals, we continue with her antiretrovirals with the usual timing. And then on discharge, and this is something new, we give her 2 months of antiretroviral supply. And this is to account for, as I mentioned at the beginning of the talk, this gap that we know exists in our programs where often women have been getting their antiretrovirals at antenatal clinic. They deliver, but they don't always then have a good plan in terms of their follow-up. They don't always know where to go. So we want to make sure that women have got enough time to sort of figure out how they're going to get their next course of antiretrovirals rather than sort of leaving them without ARVs. A known HIV positive woman who's not on antiretrovirals, she gets a stat dose of nevirapine. And so where previously we used to give Truvada as the tail, we don't do that anymore. We will start this woman on her first stat dose of TLD, okay? And then from the next day onwards, we will continue with her antiretrovirals after we've done some counseling around understanding her future fertility intentions and all the appropriate counseling that needs to go with this. Okay, so we no longer give the tail and we no longer give the 3-hourly AZT that we did previously. We need to ensure that we assist the woman with these linkages back to care in the immediate postpartum period. Okay, as I said, this is a high-risk period for poor adherence. We know that the woman is undergoing a tremendous number of different things postpartum, including a new baby who's probably not sleeping. She's probably sleep deprived. And also, we know that this is really a danger time for that break in linkage between her antenatal care and then her postnatal care. So we need to communicate the follow-up appointment dates for the 6-day visit, make sure that she has chosen where she's going to actually go for her 6-day visits, and then provide necessary referral letters for that process. We also need to provide her with an antiretroviral transfer out letter to make sure that if she is planning to go to a different facility, to make sure that there's no break in her antiretroviral care. We need to make sure that she understands the importance of continued viral load suppression, both for her own health, but for that of the baby, and that she's going to need to anticipate the potential challenges. As we've discussed, it's not the easiest time in a woman's life, and so she just needs to think about how she's going to actually overcome any of these challenges. We can also link the woman to some sort of support, so Mom Connect, a community healthcare worker, Mentor Mother, or support club or postnatal club, as these are available. We really need to be focusing on integrated care for the mother-infant pair. Obviously, this promotes adherence and retention in care. Both the mom and the baby receive appropriate care and receive linked health needs. So we know, if the mom's viral load is elevated, we know how that's going to then impact on the infant. And this will help us to reduce mother-to-child transmission, respond quickly to laboratory results, and make sure that the woman and her infant remain healthy, and that we continue to promote and protect breastfeeding in the pair. To summarize, for the mother living with HIV, the focus is really on maternal viral load suppression, and that's the most important goal of our prevention of mother-to-child transmission efforts. And we need to do this as early as possible, as quickly as possible, and it needs to be as durable for as long as possible. And this is at antenatal, delivery, and then in the breastfeeding period and beyond.